A staggering 70% of patients who suffer a heart attack are previously classified as low risk by traditional metrics. And to add to the puzzle, over 90% of stress tests, a common tool to assess heart health, return normal results. That leaves both doctors and patients in the dark about the actual risk of heart disease. Then suspicion remains high due to family history or specific symptoms, and the next step might be a coronary angiography. It's kind of an invasive procedure that surprisingly reveals less than 38% of its subjects actually have heart disease. Despite its necessity, in certain cases, this procedure is not only expensive and painful, but also turns out not always the best approach for individuals at risk. Today, we're on the brink of a revolution. Thanks to advancements in artificial intelligence and imaging technology. Today, I am thrilled to welcome a pioneer in these advancements, Dr. James Min. Dr. Min is a board certified cardiologist whose career has been marked by groundbreaking contributions to cardiovascular disease, prevention, and imaging. With a robust clinical and research focus on coronary artery disease, Dr. Min has published over 500 peer-reviewed manuscripts, significantly advancing our understanding and treatment of heart disease. His work has been supported by numerous grants from prestigious institutions like the National Institute of Health and the Dalio Foundation. He's been at the forefront of landmark multi-center clinical trials, shaping the way we approach cardiovascular health today. His latest venture into the development, validation, and dissemination of Cleerly, a AI-based digital care platform, making a significant leap forward in how we detect and manage coronary artery disease, bringing decades of clinical trial research directly into daily clinical practice. Please join me in welcoming Dr. James Min to our show. All right, Dr. Min, welcome to the show.
Greg, thank you so much for having me.
All right, man. Appreciate it. So you missed my intro, and I basically gave you all the flowers. You didn't get to you didn't get to hear any of that. But I'd like to hear your own story, man. So how did you kind of get into becoming a cardiology and then getting into developing Clearly? What was your journey? How did you get here?
Yeah, I mean, I went to college at the University of Chicago. Always thought I wanted to do science for a living, not medicine per se, and ended up going to graduate school. But it was fairly socially isolating being in a lab, and I just wanted the human interaction. So I ended up going to medical school and did all my postgraduate training at the University of Chicago. I always liked cardiology, like it just was it's the number one cause of death. So the public health impact of trying to study the disease was something that interested me. And I was just always interested in vascular biology. And so just lended itself towards studying coronary heart disease, the cause of heart attacks. So yeah, my plan was always to go into interventional cardiology. So, at the time it was putting in stents and things like that. But in 2003, I saw a non-invasive CT scan, a picture. It was from what's called a 4-slice CT. Now we have 1,000-slice CT scans, and I thought this was going to fundamentally change our understanding of heart disease. And so it was the first time that non-invasively you could sort of open up the arteries of the heart and look on the inside with a non-invasive picture that was safe as an X-ray. So I sort of moved at the last minute and switched into imaging rather than interventional cardiology, and that's sort of how I started my.
That's awesome. So how was that transition? Did you find it easy, difficult? Was it like learning a new language, going from cardiology more on the imaging side of things?
Yeah, it was. I remember reading all these physics books on how a CT scanner works and how detectors are made and all of this kind of stuff. And so, yeah, I mean, that was the fun of it. It was like learning something brand new and knowing that it was going to be applicable to, the study and the treatment and the evaluation of coronary heart disease. And so, yeah, and it was really exciting time. Like the 4-slice scanner was replaced by the 16-slice scanner. That was replaced by the 64-slice scanner in 2005. That was the first time it became sort of clinically sort of viable. So the difference between those three scanners is just the breath hold. The 4-slice scanner required you to hold your breath for over 2 minutes in order to get a scan done. The 16-slice scanner required about 45 seconds to hold your breath. And then the 64-slice scanner just required a 5-second breath hold. Now this current scanners are like 1 second breath hold and you can image the entire heart in 3D. It's fairly remarkable what these vendors have produced. So yeah, it was a lot of fun to learn it.
Now, for those who are not in radiology and who have never worked in the CT world, when you say slice, are you meaning like an imaging slice, kind of like an MRI where they're taking slices of that body part?
Yeah, so you can
Okay.
think of like a CT scanner as just a fancy X-ray machine. So when we image things in medicine, there's only so many ways you can image something. You can image it with light. That's an X-ray or a CT scan. You can image it with sound. That's an ultrasound. You can image it with magnetic fields. That's an MRI, and so on. For the CT scan, you can think of it just sort of as a fancy X-ray. And so what happens is, let's say I have a flashlight, and and I'm pointing it at my computer monitor. On the back behind the computer monitor, you see that it's dark because there's a shadow. That's the same concept of what a CT scanner is doing. And so when I talk about slice, it is like sort of taking the body, imaging the body, and then cutting it up like a loaf of bread into different slices. And then now, because the body is 3D, you can pick up the body and you can turn around in every slice and take a look at the heart and the heart arteries in 360 degrees.
It's awesome. Now, we're going to talk more about the Cleerly scan. That's kind of one of the big reasons why we're here, really the main reason, if you want to say the only reason why we're here, right? Besides getting into heart disease and why it's important to assess the risk. But you kind of had an interesting journey here because um, for me, I'm blessed enough to, my degree is in biomedical engineering. And so I got into research and I realized that it's such a different world, man. And when you're in the lab doing research, you're just so removed from the actual clinical application. You got your petri dish, you got your computer, you may have your animal study, and then you write your papers, and you're like, well, I hope some doctor out there 10 years from now is going to use this, right? Because it takes a little bit of time to get there. Now, you've been lucky enough, and just fortunate enough, I'd like to say that, to actually see both sides of it and actually take your research and apply it to clinical application. So how, I guess the question I want to ask you here is, what was the inspiration, right? Because again, to put it in perspective, sometimes we get stuck in our box. Like we're in academia, we're in research, we're in clinical, and we stay there. And that's where you live, and that's where you live until you retire, right? But you kind of cross that line. What was the inspiration for that for you?
Yeah, it's interesting that you asked that. Like, so, I used to go to, so my background is I spent about 15 years working at Cornell Medical College and New York Presbyterian Hospital. And there we ran a bunch of large scale clinical trials, really using this imaging as a tool, just as a tool to better understand coronary heart disease, to see what we were seeing on the image as it related to the phenotype of disease, how that affected somebody's long-term outcomes, and then could we influence the natural history of those outcomes in a positive way by reducing heart attacks and so on. And so, the smallest study we ever did was probably a couple hundred patients. The largest was probably 25,000 patients or so. And we always kept the outcomes. Like, we wanted to understand how what we were seeing could better take care of patients. And like from your own personal experience, but as an academic physician, I used to go to a lot of these scientific conferences or medical conferences. And then I remember somebody pulling me aside one time and saying, like, you're the only person who comes to an imaging conference and never shows a picture of the image. All you show is picture of sort of patient health outcomes and things like that. And I said, well, I thought about it, and I said, it's because fundamentally, I don't care that it's an imaging tool. I just care that it's the most robust, strongest tool that we have to really evaluate patients' heart disease, and then to be able to gather the insights to really treat them in the most personalized fashion. And then all of the questions that we asked so I think of the research as step two, because it was all the questions came from the patients. Like when you were taking care of a patient asked you something, and you start scratching your head and said, actually, that's a good question. I don't know the answer to that. And then you design a large scale study around it to better understand that question. Once you got that research, you could then directly apply it back to the patient care and make sure that you're constantly improving and iterating on really ideal prevention. And so for me, like, that was sort of where it came. At some point, like, we had started a prevention program doing exactly what we do at Cleerly, but what we were just doing it extremely manually at Cornell. And it was just quite successful in preventing heart attacks. So we thought, how can we scale this and allow the tools to be delivered to the rest of the world? And that's when we decided to start Cleerly.
That's awesome. So let's dive into why Cleerly, right? And I think to understand why, we need to kind of walk this back to atherosclerosis and plaque. So, for the listener out there who's not a doc, who's not in research and not in cardiology, what is atherosclerosis?
Yeah, atherosclerosis is like an insidious disease that's very, very common. It's almost universally present in most adults. And it is the cause, it's a plaque buildup, it's plaque essentially that builds up within the walls of the artery over many years. And that plaque, it turns out there's many different types of plaque. We didn't know that until we started studying that, in large patient cohorts. But the plaque is the cause of heart attacks, it's the cause of strokes, it's the cause of vascular dementia, it's the cause of erectile dysfunction in most men over the age of 50. It's the cause of slowing physical activity due to blockages in the arteries in the legs and so on. So it's a systemic, ubiquitous process. By far, the most dangerous one or the most common one is coronary heart disease or atherosclerosis in the heart arteries that are the cause of heart attacks.
So, how do people get plaques?
Yeah, it's a really good question that we don't really have the answer to.
Right.
It's not a single cause, that's for certain. It's like definitely a multi-variable disease or a multi-parametric disease, meaning there's many contributors to it. A person's genetics can contribute to it, but that's not universal. You can have environmental insults. By environmental insults, I mean air pollution or smoking or things like that. You can have atherogenic lipids, or a simple way to say it is just bad cholesterol and high cholesterol. You can have metabolic derangements like diabetes and prediabetes and metabolic syndrome. There's racial differences, right? So we see a high incidence and prevalence of heart disease in the Middle East and India and South Asians over, some other countries. And it's just there's probably thousands of risk factors of disease, and we probably haven't even scratched the surface. I think what Cleerly does is it takes all of those thousands and thousands of risk factors that have influenced the patient's heart over the course of their lifetime and actually integrates it into a single metric that can be tracked and followed, and that is atherosclerosis, because that is the end result of all of those processes.
Yeah, I'm glad you brought up the multifactorial portion of it, because a lot of times in my world, in the naturopathic world, we kind of start with like the big three, 4 to 5, right? It's the kind of like the diseases of lifestyle, diseases of aging, the cellular diseases, where it's like, okay, well, how what's causing plaque, or what puts you at the risk for plaque, right? And that's when we start talking about, hey, are you dealing with obesity? Are you sedentary? Are you dealing with a lot of inflammation? Are you dealing with insulin resistance? Are you dealing with high cholesterol? Not just high cholesterol, but the actual LDL and small dense LDL and the VLDL. And there's a lot of I had a whole podcast talking about the size and the density and all that stuff. But it's really from a perspective of the heart, it's like I said, there's genetic factors, things out of your control, but things we do have control over is what we eat, and are we working out, and are we smoking, are we drinking alcohol, are we living a toxic polluted lifestyle? So I'm really glad you brought that up, because that puts you at a higher risk, especially if you have
Definitely
the genetics
does.
behind you.
Yeah, I
Behind you.
mean,
So
like in our prevention program, we always started with lifestyle first, right? If you could control things with lifestyle, that's great. In many patients, you cannot, and so we then would go to medical therapy. But I think that most of the heart disease in this world can be managed conservatively, right? You don't need an invasive procedure, you don't need surgery. You can really, and then the earlier you take care of this issue, this atherosclerosis, the easier it is. It's like taking care of the problem before the horse gets out of the barn. Once it gets out of the barn, it's tough to put back into the barn. So I think that the way that we're approaching disease prevention is very similar to the way you do as well.
So now let's get into the fun stuff. Let's get into the Cleerly stuff, right? And so I think to me, as I was kind of doing my research on it, and I've had a few patients go through the Cleerly scan as well, is the first thing is like, look at the question like, okay, what are you sending me in for? Like, what is this image you're doing? And I'm like, oh, it's a CCTA. And there's like, what is that? And I'm like, oh, that's a coronary computed tomography angiography. And then you look at me just like I said, what is a CCTA? We're back to what is a CCTA, right? And
Yeah.
so that being said, when it comes to this imaging study, the CCTA, how does that help detect coronary artery disease?
Yeah, it's a great question. If you think about coronary artery disease, the disease is the plaque. It's the atherosclerosis. At some point in time, the plaques can grow and they can encroach upon the inside of the artery and start to narrow it. That's called a stenosis. People call it a blockage, a narrowing. At some point, that narrowing may become so severe it starts to impede the blood flow to the heart muscle. The arteries are there to deliver the blood and the oxygen to the heart muscle. If that happens, then people can experience symptoms, chest pain, shortness of breath, and that's a concept called ischemia. So atherosclerosis, stenosis, and ischemia. For the last 50 years in cardiology, we've studied ischemia by stress tests, right? You run on a treadmill, see if you get chest pain, take some pictures of your heart, see if the blood supply to the heart muscle is adequate. If that was abnormal, we would send people to look for a stenosis or a narrowing. You hear all these people saying, oh, my doctor told me I have a blockage. But nobody ever asks the question, the blockage from what? And what is causing that blockage? How much of that, how much of that plaque is there? What type of plaque is there? And so it occurred to me just a couple of years ago, even after we started Cleerly, that heart doctors have never actually measured heart disease. We're really good at measuring indirect markers of heart disease, like cholesterol is an indirect marker. If you have high cholesterol, you probably have a higher likelihood of heart disease, but who knows? It's pretty unreliable. We're really good at looking downstream of heart disease at that concept of ischemia. For your listeners, just to put it in a layman's term, if it's raining and your gutter on your house is trying to take all the water and get it off the roof, if you've got leaves clogging up your drain, well, that's the problem, is the leaves, right? But then what we've been doing is measuring the rate of the water coming out of the end of the drain. That's ischemia, or a reduction in flow. That's not fundamentally the problem. The problem are the leaves, and we need to take care of those leaves. And we need to get it to a point where we identify those leaves at such an early point that it doesn't cause a problem, that we prevent it from clogging up the drain. And so it's always like, I always shudder a little bit when people are like, oh, my doctor told me I have a blockage. Well, that's not the problem. The problem is the plaque that caused that blockage, and that's what we need to be treating. So Cleerly offers solutions to measure all three of those things: atherosclerosis, stenosis, and ischemia, but really with an emphasis on let's get you as early as possible, because that's the time that the atherosclerosis or the plaque is so easily treatable.
Great. So, with that being said, I'm glad you brought that up. You mentioned the three things that it's measuring is the atherosclerosis, the plaque, the stenosis. It's got all that, which is great. Now, is that different than just say, hey, my doc sent me in for a heart CT scan? Is it the same imaging? Is it the analysis of the imaging or the processing of the images that sets it apart?
Yeah, it's a really good question. So there's two types of heart CT scans. One of them is a non-contrast CT scan. That means you don't inject any contrast. The other one is a contrast enhanced CT scans. We inject a little bit of iodine-based contrast, and then you can then opacify or light up the insides of the arteries and really see different kinds of things that the non-contrast can't. The non-contrast CT scan is often referred to as our coronary artery calcium score, while the contrast enhanced CT scan is often called a coronary CT angiogram, meaning it's taking a picture of your angio means vessels. And so the difference between those is that the contrast enhanced CT angiogram can look at non-calcified and lipid-rich plaques in a way that the non-contrast can't. Turns out when you look at every major landmark study that has ever been done, the bad actors are the non-calcified ones. And in particular, those ones that are very dark on a CT scan that signify that they're cholesterol filled and fatty filled and so on. Those are the ones that Cleerly helps to identify with great accuracy. In addition to that, it also can measure things like measure the narrowings. And then on a typical CT scan, a human reader can't determine blood flow or estimates of what we call fractional flow reserve. It's just a measurement to figure out whether or not somebody has perturbations of flow and pressure in their arteries. And so we have a tool that computes that for users, so that because they can't do it on their own.
Cool. Yeah, no, it's a fascinating when you actually see the study on the doctor side here to actually, and what I like about the imaging as well, and I kind of wish I could cut away and show it, because it actually can show you the vessel on the heart. So I'm looking at the LAD, I'm looking at, all of it, man, across, and I'm just like, oh, this is so cool. Look at this, it's right here. And you can straighten it out and see like where the plaque is and determine what type of plaque it is if the person has it. So with that being said, what I found really cool about it, it can actually give you the amount of plaque,
Yeah.
which is fascinating, right? So you can actually say that as well. But here's the deal, I guess, and this is going to sound like it's a simple question, but I want to make sure just for listeners and even for the doctors that are listening to that is when you find those high risk plaques, those non-calcified plaques, how can we take that data and say, hey, this is how, and use that as a preventative measure? As in, you take the data, I found a plaque. Now, what's next for the patient at that point? And can we
Yeah.
change it?
Yeah, it's a good question. Like, so I'll emphasize, like, right now we are regulated as a decision support tool. So we are here to support physicians and providers and patients in their care. Ultimately, the care will go to whatever the doctor thinks is best. I can tell you my own experience as a physician was that it would help guide my selection of lifestyle interventions, medical therapy. 10 years ago, we had statin medications and just for some aspirin to treat coronary heart disease. We've got over a dozen kinds of medications now in our toolbox. The toolbox is so heavy, but it's hard to figure out who to treat and how to treat them. And that's where I think the Cleerly analysis can really help support doctors in better understanding their patients' hearts, help support patients in better understanding their conditions. And so, as you pointed out, like you said, yeah, you can cut it up in 3D and make different slices and turn it all around. One thing that I think Cleerly has really focused on that I hadn't when I was in at Cornell and New York Presbyterian was this concept of quote unquote implementation science. What does that mean? Well, it's one thing to have a breakthrough innovation. It's another thing for people to actually understand it and then know how to use it. And so we spent an enormous amount of time thinking through who are all of the stakeholders across the care continuum and how can we help take this advanced phenotypic imaging and translate it in a way that everybody can understand, providing all of the metrics that whoever the stakeholder is could use in their life. And so who are these stakeholders? Well, there's the imager, the radiologist or the cardiologist who's reading. They have certain needs. And then there's the general cardiologist who's taking care of patients. There's a preventive cardiologist who thinks of very different things, an interventional cardiologist, researchers, primary care physicians, advanced practice providers. And the most important stakeholder is the patient. Because what we realized is that when we were trying to review all of these images and point out these things to patients, like, it was a language that we didn't share, right? It wasn't a common language. So we spend an enormous amount of time really taking all of these analyses and presenting it to people in a way that everybody can be empowered by the data in a, independent of who you were. So that was also a very big focus of Cleerly.
That's good. And there's a lot of stakeholders, man. Just make
There are
sure
a
everyone
lot of
understands.
stakeholders,
No,
yeah.
it really is, right? And sometimes they're not on the same page. And I think that's where having that information, having that picture, like, look, this is what it is versus a theory or a concept, right? This is actual imaging. This is where you have the issue at. Now, that being said, is this a test that you think everyone should get? Or everyone over a certain age should get, or is it more based on your risk factors, your genetic, kind of like your genetics, your family history? Is there a profile of a patient you say, hey, you need this right here, right now?
Yeah, so that's a great question. Like, so, I mean, because like our company offers that comprehensive evaluation of coronary artery disease, like we believe that we fit across the continuum of care. So from the earliest start of a disease to the latest stage of disease, we think that across that continuum, we really offer insights that other tests and modalities cannot. To your point, right now in fee-for-service medicine or, typical, I go to the doctor, I submit my insurance card and, that kind of thing. We typically focus on symptomatic patients, right? Patients who present in with chest pain or shortness of breath. And that's where we're solidly focused. And for that, we've achieved a good amount of insurance coverage and reimbursement, and so that it can be paid for by the insurance providers. That's where a lot of our focus is. And in parallel to that, we're trying to do a very large clinical study to tackle what I think is the biggest unmet. So if you think about, I'll call it over half of the people who will be diagnosed with coronary heart disease will be diagnosed by either having a heart attack or dying. Like they don't have any symptoms before their event. And so it occurred to me that if you're sitting in the office waiting for patients to come to you, they never will because they die at home before they ever have any symptoms. So what we announced at the American Heart Association meetings last November was a large-scale randomized control trial called Transform. The purpose of this is to take completely asymptomatic people and randomize half of them to just usual care. I'll check your cholesterol or see if you have diabetes or high blood pressure, versus Cleerly guided care, where we actually take a look at your heart arteries as an individual, as a person, and then treat according to that. That trial has started. We're enrolling for that trial right now. And the goal really is that if we can substantially improve patient health outcomes by doing personalized medicine, looking at actual disease, I think that then it would argue for a paradigm shift, right? Where we stop waiting for symptoms in late stage disease and then go upwards in the evaluation to the time the patient presents with the earliest sign of silent disease that can only be imaged by a coronary CT angiogram. So that's the hope, is that we can try to really tackle every single patient at risk, whether you're symptomatic or not, that we want to get away from symptom-driven care, but really to focus on disease-based care.
That's great. That's great. And that kind of leads me into the next question here. And this is kind of the hard-hitting questions, if you will, Dr. Mann. So, if the patient, I'm speaking to my patient here and they're like, hey, I think based on your history and your lab work, I think you should do a coronary CT angiogram and I want to do the Cleerly scan. And then obviously, because you mentioned it, because it's in a, kind of its insurance isn't covering that part of it right there. If the patient looks at you and say, well, why don't I do it Cleerly? Why don't I just do a coronary CTA? Like, so what, from the, to the patient, how would you explain that? What's the benefit of doing the Cleerly versus just doing the traditional coronary CTA?
Yeah, I mean, the traditional CTA, like we tried to do that, like in our heart health program at Cornell and in our research studies, and to comprehensively analyze plaque in the arteries took us 8-10 hours per patient. So I can assure you that nobody's doing it across the country because it just takes too long. Even when we could do it, what we realized is that when you take non-trained people to do it, then the results are highly inaccurate. So we can provide this at scale with a rapid turnaround time and with a characterization of the types of plaque. So it's not just how much plaque you have. That's obviously the more you have, the worse it is. But it's the type of plaque in the prior large-scale landmark studies that have been demonstrated to be the strongest predictors of who's going to have a heart attack or not. So those kinds of insights, I think, that you wouldn't get from a typical, heart CT angiogram. And then in addition to that, like even when you get it, I don't think anybody can understand it unless you're an advanced imager. And so to take those translational tools and to really be able to dissect that at the personal level in a way that that person can actually understand and be empowered by, I think that Cleerly offers that. And then lastly, like for those patients who have significant disease, we have a device out there that can compute and calculate things that doctors, no matter how long they looked at it, couldn't be able to derive that kind of information. So I think there's a wealth of information that you can get from the Cleerly analysis that's sort of a large step forward from where we were 5 years ago.
So when I kind of went through the Cleerly, and I met with my rep, and we have great conversations about Cleerly and how it works. And one of the things, when you go to the website, you look at this interface or this interaction, if you will, between the analysis and AI. And I know AI has been such a hot button topic the last couple of years. It's like, oh my God, AI is taking over. The robots are going to take over, and it's going to be the Terminator out here. And has anyone ever seen a movie? AI is bad, right? And and this is where, in my opinion, I think in healthcare, that interface, man, that kind of combining it and using the advantage of it is going to be super amazing in the future, because it can do things faster that we just can't do. Now, for that being said, and I'm going to ask a really straightforward question with that: how is AI integrating with what you're doing with Cleerly? Like, is it, here's the imaging, run it through AI spits out this, and then now I take that data, analyze it, and present it to the patient? So I guess to be, that's kind of a blunt way to put it, But how does, you may have kind of answered that with being the analysis of the imaging here. How does Clearly leverage AI to help the patient?
Yeah, it's a great question. I mean, it's almost end-to-end AI, like at every single step. Like, so, there's a whole bunch of different steps in the processing of the image and the reconstruction of the images. Everything is sort of infused with AI. That was part of the phenotype. Like when I think about AI, like I think about it as an applied, person. Like there are people who are more basic and methods driven, and then there are people who are applications driven. The AI will revolutionize medicine, no doubt. Like, I mean, it'll revolutionize the world. For me, the AI is just the best tool that we have to be able to most accurately and at scale be able to deliver the greatest number of actionable insights to providers, physicians, and patients. And so we adopt the AI similar to the way we adopted imaging. It's not imaging that I care about. It's the information about that patient that the imaging offers, which is why we adopted it. Same thing with AI. We could have done a lot of these things with different approaches that are more legacy approaches, but we just adopted it because it delivers the best and most accurate information at scale.
Do you think AI is going to this is that tough question, man, about how AI replaces people, right? Do you think AI is going to take away some of the roles of your traditional radiologists?
I think so. Like, I mean, I think that the field of radiology has a really unique opportunity right now. So, I mean, the analogy, like when I was in medical school, we weren't on computers, we were on film. And so so every day after we were rounding on the patients, we would go downstairs and the radiologist would show us the CT scans or the MRIs and teach us. So at that, the radiologist was the holder of knowledge, right? He was the doctor's doctor, or she was the doctor's doctor. I think given all of the advancements that are happening, not only in radiology and imaging, but also omics, multiomics, genomics, proteomics, like inflammatory markers. You mentioned, small LDL particles and VLDL, like advanced atherogenic lipid profile. I mean, all of this is so complex, and so I think that the radiologists, because they hold the strongest piece of information, the imaging, they can become that doctor's doctor, the holder of knowledge, that allows somebody to be able to integrate all of that. But I do think the AI is definitely going to replace a lot of the stuff that we do across the board. So if anybody thinks that that's not going to happen, I'm here to tell you, I think it is going to happen. But I think that just presents greater opportunities where we can do more with what we have rather than less.
Now, as AI becomes more prevalent in healthcare and how we diagnose and how we analyze, what is what is your vision for Clearly as these advancements, increase and take a stronger hold?
Yeah, it's a great question. Like, I mean, the transform randomized control trial that's ongoing now would be a big deal for us. Like, I mean, I think that would be a big step forward to really open up the opportunity for screening asymptomatic people. That's not today, right? Companies don't provide it, and commercially we're very focused on those patients who have chest pain or shortness of breath. But that would, I think, really fulfill an unmet need that is, I mean, it's the number one public health epidemic. Like, I'll give you a couple of statistics that may surprise your listeners. There are 40% more cardiovascular deaths than all cancers combined. Like, I mean, and in 2020, there were twofold more cardiovascular deaths than deaths from COVID-19. That's how big this epidemic is. And, it sort of became the punchline, like, oh my gosh, you almost gave me a heart attack. Like, it's not, everybody knows somebody, right, who looked pretty healthy and then ended up dying from heart disease. And so I think we need to tackle this. And I'm convinced that you need to go upstream of symptoms, but we got to prove it. So that's why we're doing the randomized trial. And then I think the adoption of all of these other new innovations and how you integrate them all together, the AI that you mentioned, the multiomics, there's so much interesting stuff happening in that realm. All of the inflammatory markers, the cholesterol markers, like how do you use them all together but in a simple way that doesn't confuse people, that really guides people to better care.
It's awesome, and I appreciate it. So, man, this has been great. This has been great, and I think I was about to summarize the show, and I think you kind of just did, And so, in the big picture here, and I hope people take away is that heart disease is can be insidious. It's not all the time symptomatic. It's not when you have chest pain. It's not when you gain a bunch of weight. There's a lot of factors that can cause those plaques and cause that inflammation in the heart and cause endothelial dysfunction. But we didn't get into endothelial dysfunction. That'd be a whole other podcast right there. And all these things come to play. And the role of medicine, I think the future role of medicine is going to be detecting, identifying these things before they happen so that the patient can get treated and advance and live that full healthy life. And I believe clearly from what I've seen from it is going to be at the forefront of that, especially in the heart disease world, because what if, that question you started, what if you can predict it? You can see what's going on before it gets worse. What if you catch that plaque before it becomes now calcified, before it breaks off, and before it causes damage, right? And I think that's where we want to take it here. So I am all on board with it, man. So with that being said, what is your takeaway for the listener here? What do you want people to walk away from as they close out this episode?
Well, I'll give a startling statistic that may surprise people, but I'll couple it with optimism and empowerment. Like the startling statistic is that people think of heart attacks as happening in the elderly, but if you look at the data, the sudden coronary death due to heart attacks, the average age is 50, right? So it's not a disease of the elderly. It's people who are in their prime, who have young kids and who are going to work and taking their kids to school and little league and so on. If you look at certain higher risk populations, the Middle East comes to mind. They have an average age of heart attack that's 10 years earlier than the US. High risk occupations, especially the firefighters. We do a lot of stuff with the firefighters. Like they have an average age of heart attack 10 years earlier than the general population. So that all sounds really draconian and depressing, except it's preventable. Like so once we know the issue, doctors can definitely treat this condition to prevention. So, and that is the goal, right? The goal is not to not form plaque. The goal is to not have a heart attack. So I think that the future is bright if we can see it. Like if we can just identify the people with precision, like pinpoint people who are at risk, and really, I think then the patients and the doctors can figure out the treatment plan to really prevent this disease from causing catastrophic events. And Cleerly's devices are there to support that provider and that patient.
Amazing. Awesome, man. Well, thank you. It has been an honor and a privilege to have you here talking about Cleerly and all the great things that it can do and will be doing in the future. Before we let you go, man, if people want to know more about you and the studies that you're doing and Cleerly, where can they find you and find more information?
Yeah, absolutely. Like it's www.cleerlyhealth.com. Cleerly is spelled with two E's, not and so it's cleerlyhealth.com. And if you want, you can go to clinicaltrials.gov and look up all of the studies. Just type in Cleerly and you'll see all of the studies that we're doing right now.
All right, awesome. Thank you. All right, everyone. It's been another great episode. Again, we want to thank Dr. Min for coming through and giving us some great information on Cleerly and CCTA and Plaque and all those good things that you can take to empower yourself to learn more. I encourage every last one of you to stay informed and learn about these innovative health technologies like Cleerly, because these things are happening and they're changing medicine, and we want to be aware. Not just aware, but take advantage of it so we can live those longer, healthy, optimized life. This is Dr. Greg Jones of the Optimization Academy, and I will see you soon.